Okay, let's start. So, welcome everyone to today's panel, The Ethics of Conducting Health Research in Humanitarian Settings, Principle, Practice, and Reflection from the Field. My name is Lydia, and I'm one of the co-hosts of today's event. This panel is organized by the Center for Interdisciplinary Research on AIDS, CIRA, at Yale University, a research center supported by the U.S. National Institute of Mental Health, and in collaboration with the Yale AIDS program and support from the Yale MacMillan Center. Today's seminar is being recorded for archiving and future viewing. Presentation slides and recording will be available at CIRA website in the coming weeks. Today's event attendees will also be notified by email once these resources are available. On your screen is a screenshot of CIRA website, cira.yale.edu, where you can find information related to affiliated research projects, investigators, community partners, and presentation from past events. A quick overview of today's panel agenda. We will start with some talking points and reflections by the panelists, which will be followed by a facilitated panel discussion. Then we will continue with Q&A to respond to participant questions. And lastly, my colleague Julia Rozanova will have a few words for closing. We would like to thank the attendees who have submitted questions ahead of time that will inform today's discussion. This panel has attracted attention from over 230 people from more than 30 countries, representing academia or research institutions, healthcare systems, non-government organizations, and many more. For the Q&A, please submit your questions or comments using the Q&A feature at any time during the panel. You can submit your questions with your name or anonymously, and attendees can view all the questions submitted, and you can upvote questions most important or relevant to you or your work. This can help us identify questions that more attendees would like to be addressed during the Q&A. And at the end of the panel, a brief evaluation survey will pop up on your browser. Please take a moment to evaluate today's event and provide suggestions for topics and speakers for future events and activities. We are very honored to host four esteemed panelists today with expertise and experience relevant to the topic. The panel will be moderated by Dr. Laura Bothwell. Dr. Bothwell is an ethicist and historian of public health. Her research examines social, historical, and ethical dimensions of epidemiology with a particular focus on randomized control trials. Dr. Bothwell also conducts work at the intersection of climate change, epidemiology, and ethics. And with that, I will turn this over to Dr. Bothwell. Thank you.
Thank you so much, Dini. Thank you to everyone who's joining us today, for the sponsors, CIRA and the NIH National Institute of Mental Health, and a special thanks to our esteemed panelists. There's a great ethics literature looking at the ethics of conducting research in settings of humanitarian conflict, but today we're able to hear directly from individuals who have personal experience, professional expertise. So I'm looking forward very much to hearing what they all have to say. We're going to open with some brief reflections and introductions from our panelists. The first would be Rick Altice, a professor here at the Yale School of Medicine, and I'm delighted to turn it over to Rick.
Sure. Laura, thank you so much. So just to give a little bit of brief background, I'm very interested in the health-related research at the interface of infectious diseases and substance use disorder, and really have a human rights foundation for all of this research, as I spend a fair amount of time, or I and a very large team of people, where we focus on health equity in vulnerable populations, such as men who have sex with men, transgender women, people who inject drugs, people who engage in sex work or deprived of liberty, and more recently, refugees. We've got a number of multiple global health research training centers in Eastern Europe, in Ukraine, Moldova, and Georgia, Central Asia, in Kyrgyzstan, Kazakhstan, and Tajikistan, Malaysia, in Southeast Asia, and where I am currently in Peru, in Latin America. And some of the experiences that are humanitarian situations that have impacted our research over the last several years have been certainly the war in Ukraine, not only in 2014, but again now. issues around migration, mostly economic migration in Central Asia. And then, of course, in almost all of our settings, there has been humanitarian issues related to COVID-19, which have emerged, and I think will be a sort of a major theme through today. On the next slide, I have a couple of just a little bit of a background, which is how I'm going to anchor a lot of the comments today, is that I've been working in Ukraine now for 20 years. I've not been back in the last 2 years, but we introduced buprenorphine, and I was there during the Orange Revolution, speaking of a humanitarian setting. 2010, we had a large grant to begin scaling up HIV prevention using medications for opioid use disorder, where we encountered our first bump, if you will, and that was the Russia's invasion of Ukraine and the illegal annexation of Crimea. And then, of course, the COVID pandemic in 2020, where we did major disruptions related to telehealth and policy changes. And then more recently, we've been very actively involved in the second invasion of Ukraine. And sort of the story that I'll be telling later on has to do with sort of these continuous experiences and how one adapts and changes to disruptions. Thank you very much, Laura.
Thank you so much. We're turning next to Dr. Lydia Barakat, also from the Yale School of Medicine.
Thank you, Dr. Bothwell, and thank you for the organizer. I feel honored to be part of this panel discussion. So I am an associate professor of medicine at Yale School of Medicine, section of infectious disease, and I'm the medical director of the outpatient services at Yale. Infectious disease. I was born and raised in the Middle East. I lived through the Civil War since 1976 to 1995, and I was personally and my family displaced during the war for several months and years. My area of interest is workforce development with specific, focus on HIV and infectious disease. Nationally, I'm part of a consortium for HIV workforce development. And globally, I was involved in training programs in Liberia after the Ebola outbreak and their workforce shortage. A research project in Liberia on HIV prevention and cascade of care, and currently collaboration for initiation of PrEP. I also have collaboration in Lebanon to have HIV workshops to increase the workforce development, as well as in Rwanda for HIV and ID curriculum development. As far as things related to war, I was also volunteered in the refugee clinic here at Yale, especially after the Iraq war, to help with the Iraqi and Syrian displacement, because I speak the language, and this helped also ease the trauma for our patients who were displaced to the United States. And during the COVID pandemic, I was the first physician who launched the preparedness for the COVID unit at Yale New Haven Hospital and all the ambulatory for ID, especially as far as readiness and also research and the ethics related to all of that, including the research. Thank you for having me, and I look forward to hear the other panelists.
Thank you so much. The next panelist is Dr. Madelon Baranoski from the Yale School of Medicine.
Yes, it's a privilege to be here and to learn from all of the other panelists. I'm a professor in the School of Nursing, or School of Medicine in the Department of Psychiatry, the Lawn Psychiatry Division, and I serve as an IRB chair of a number of panels for the Yale IRB. Most of my experience with this is vicarious, interacting with people who have suffered experiences related to humanitarian crises, working with persons who are seeking asylum, and also at home here, people caught up in a crisis that reflects our difficulties in social justice, racism, marginalization. On the next slide, please. As I thought of being on this panel, I reflected on some things that I've learned from my colleagues and in my own deliberations around research is that ethical principles must always apply: respect for person, beneficence, justice, and add an additional one when we're in global research to community respect. But their application can vary depending on the demands of the situation. And beneficence requires removal of obstacles to sound critical research. We can't get in the way of making differences on a social and global level. And during humanitarian crises, community collaboration is critical to assuring ethical research, the quality of research, and making a difference. So thank you for inviting me to this panel.
Thank you. And last but not least, Dr. Dónal Omathuna from the Ohio State University College of Nursing.
Hello, everybody, and thank you very much for the privilege of being part of this panel and contributing to these discussions. I am originally from Ireland, and that's where my interests in the whole area of disasters developed, and was very actively involved with the Cochrane collaboration, which focuses on conducting systematic reviews of evidence for various healthcare interventions and research related to that. And because of the 2004 Indian Ocean tsunami, Cochrane was asked to provide resources for evidence to guide disaster responders, and really discovered there was a huge gap in this area, and that led them to advocate for more evidence and more research into disaster-related situations. And with my area of involvement with them, and then also my healthcare ethics background, they asked me to kind of look at what are the ethical issues of calling for this type of research. And that really has started my last 20 years of interest and focus in this area. And through that, we were able to get funding to develop a network between ethicists, humanitarian responders, and major international organizations looking at the ethics of research into disasters. And through that, then my interests have really been around providing guidance for those going into these disaster areas, helping to provide training in the backgrounds in terms of what sorts of issues people are likely to have to address, either as healthcare responders, humanitarian relief workers, or researchers themselves. So it's kind of been a real privilege of mine to kind of be part of those training programs for people that are actually working in the field. And I've got two projects currently underway at the moment that tie into all of this. One is that between the Ohio State University and the University of Nairobi in Kenya, we have developed a master's program in research ethics for One Health and emergency research. And so we're helping to train a new generation of researchers in Kenya who will be actively working in this type of area and getting a thorough grounding in the ethics of all of the related issues. And my second project is a collaboration with Loyola University and Ukrainian Catholic University, where we're looking at research ethics issues in violent conflict and war settings. That's a project where we're going to be interviewing people involved in such areas and developing case studies and general guidelines that we hope can assist those who are going to be getting involved in that type of research. So those are my interests and background, and thank you again for the chance to be involved in these discussions today.
Thank you so much. So we have an incredible panel with extremely rich and diverse backgrounds, experiences, and expertise. So I'm thrilled to begin our discussion and hear what they have to say. The first question I'd like to direct toward Dr. Barakat. The question is, should ethical and/or IRB guidelines for conducting research in humanitarian settings differ from ethical guidelines in non-humanitarian settings? And a sub-question is, are there certain kinds of research or research activities that should be permitted in non-humanitarian settings, but not in humanitarian settings, and vice versa?
Well, thank you for this question. The short answer is yes, we should always follow ethical and, typical research requirement to a certain extent. And I try to make my answer short. When you have a humanitarian crisis, it's always an unexpected emergency. It can be a war zone or domestic conflict. It can be healthcare crisis, like the Ebola outbreak or the Mpox outbreak or the COVID pandemic or a natural disaster or even a cyber attack. And all of these are going to create a very significant sense of fear within the people who are suffering from these circumstances. Some of them can be displaced, but some of them, they have to be isolated if we have a cyber attack or in a case of pandemic. There is also the priority for them is access to basic needs and healthcare. And here we want to do good and we want to do research. And the research can vary from needs assessment, which is very important to identify area for intervention that this particular population can need. It can be understanding pathophysiology, like in COVID-19. We needed to learn a lot about what's going on with the human response, also the transmission. It can be also about drug and vaccine development, for example, the Mpox situation or the COVID-19, but also understand the behavioral factor that we've seen with HIV, with Ebola, with COVID. And then you have all the implementation science. How can we implement certain intervention that can improve outcome or prevention intervention and models of care? So this can be associated with a lot of barriers. For example, you have the urgency of the situation. If you miss, for example, certain window, you might not understand the pathophysiology of COVID-19. And these had to happen in the early stages where we didn't know much. How do you consent patients? You have physical barrier because they were on isolation. You can have language barrier. How do you consent them? And you want to start thinking outside the box and have a little bit of an understanding, how can we overcome these barriers, including providing a safe and secure place for the participant and for the people who are conducting research. So when I said to a certain extent, we have to be a little bit flexible to promote this type of research that can be also life-saving. And that's why you need somebody like Dr. Baranoski to help to make sure everybody's on track. I hope I answered your question, Laura.
You not only answered the question, but also the follow-up question, which is, how do we hold accountability for that ethical flexibility? Would anyone else, Dr. Baranoski, or anyone else like to weigh in on this?
Thank you. I think Dr. Bacarat's response was complete. It's the flexibility in the application of the ethical principles that's critical. So during COVID, what happened within the Yale community is a committee was put together very quickly to be sure that we weren't replicating research over and over again unnecessarily, that there was a combined effort or a collaboration that allowed us to target and to be certain that the same participant wasn't giving blood many, many different times for different studies at the same time. And then the IRB took responsibility to be sure that we were on call for a very quick review and to come up with an understanding of the spirit of informed consent and what was minimal risk versus above minimal risk for looking for surrogate consent or exercising even emergency guidelines that waive informed consent as long as the community agrees. So we had to get creative, and what I hope is we'll remember what we did this time, so the next crisis, we will be prepared to step up with the same mechanisms that seemed to work the first time going around.
Excellent, thank you. And I'm sure that Dónal Omathuna would have some thoughts on that as well. But I want to first turn to the next question. This one is for Dr. Altice. Can you share your personal experience in maintaining your research collaborations during crises? And also, can you comment on continuing research activities during periods of political or civil instability, or when there is risk to local researchers or collaborators and study participants?
Yeah, so I think that I can sort of point towards the current war in Ukraine as an exemplar of some of the things. And I'll just point out that, you know, there are only a few benefits of being of an older generation, and that's called experience. We've been through this before. We dealt with some of the early, but sort of not quite so severe consequences of the Russian invasion in 2014, where only 2 regions were affected. And of course, we lost all connection with our research participants in Crimea when it was annexed. And that was really quite horrible. What we did during those circumstances was we figured out ways to move our participants out. So there was some sort of experience there. And then, of course, we did the same thing with COVID. There were these disruptions. And to speak to both what Lydia and Madelon spoke about in terms of this flexibility, the one piece that wasn't said, but that was certainly one of the factors that was, Madelon was pushing me. And so, you know, she didn't say that, but it's really about involving the community. And whether your community is the academic community or the people that you're working with, to try to understand what it is that is going on and what they perceive as risks or not risks. And I'll give you some examples. For instance, we moved a lot of our communication to Telegram, which is a more secure way of communication, in some cases Signal, so that if you were concerned about sort of, you know, information getting, you know, transmitted, that would change. We changed the way that we did, you know, consent. We did, you know, verbal consent with a video. We did some of that in COVID, so we had learned from that during the war as people were moving and becoming both internally displaced, or when we would sort of reach and communicate with them as they would sort of transition into Eastern Europe or into or Western Europe, for that matter, as they were sort of leaving the country. So you have to sort of think about those sorts of things that you're doing that. And as it relates to our collaborators, what was interesting, and I can say that it was true for both COVID and the war, and as an implementation researcher, this will resonate. So my research is really quite adaptable in these things, is that, you know, we call this a disruption. These are major disruptions. And so in this case, it was an implementation disruption. And as it turns out, it ended up being a disruption that was, in some ways, it helped our system. We were treating patients for opioid use disorder. They required getting a medication every day, or they suffered horrible experiences of opioid withdrawal. So the consequences were so much greater. So one of the things that we did in terms of responding to the crisis, and Lydia can speak to this in terms of the hospital, is we moved from sort of every couple of weeks visits to, conference calls, to even getting on the call every single day and planning with new information as certain areas in the conflict were changing. And so we made a lot of adaptations, and we're trying to figure out how do we sort of chronicle that, so that this has been one of the first big wars where there's a lot going on with the West, to chronicle what are some of the best practices to do with that. And I'm sure others will be able to speak from their experiences, but we were able to, one, engage the community. We are thankful for the Zoom that we have here today in order to be able to communicate, or through other platforms like Signal and Telegram for, sort of networks of communication. And one of the things that was always on our mind is we did remember and learn from Crimea when they annexed that Russia shut down all methadone immediately. 10% of our research participants either committed suicide or had an overdose or death. And this was really, really quite awful for us. So we really ramped up and did things, quite differently and added as many protections. And it wouldn't necessarily have been the kinds of protections that we would have done in a non-conflict area, although I would say maybe with the way that cyber is working, that we do need to be thinking about those things. I won't go on and on, but we'll come back to some other questions. But these are the real world, ways that you do things, and it's increased engagement. Lydia, we were on calls every single morning at 7 o'clock in the morning in the hospital, and during COVID. So this is what you do, and you engage them, and you ask people, how do we do this? And your community will come up with very creative solutions, ones that you may not have, thought about. And then, of course, we get on the call with, Madelon and say, is this okay? And of course, we come to a conclusion around that.
Excellent. Thank you. I'm going to put this follow-up question out there, and we won't ask it right now, but there's a pattern that's emerging among our panelists in terms of adapting on the fly to new information, to new crises. And when we have to do that, oftentimes we have to fall back on our previous training, Rick, in human rights, as you had discussed, our ethics training. So I'd like to come back to this once we've heard from all of our panelists in terms of how we do make those decisions in very unpredictable situations. In all disaster scenarios, there's inevitably an element of surprise and the need to quickly pivot. So in those scenarios, we can do the best we can to prepare for the next one, but you can never predict what's going to happen, right? So in those scenarios, I'd like to revisit this question of what do we fall back on? And Rick had mentioned engaging the community, which I think is absolutely critical and a really important point. But I'm going to turn to the next question. This one is for Dr. Baranoski. How can researchers responsibly and ethically engage community members affected by humanitarian crises? And the sub-question is, how might researchers address sensitive behaviors, for example, sexual practices, injecting drug use, and experience such as sexual violence?
Thank you. A complicated and critical question. The engagement of community ought to be part of research all the time. And I think we're appreciating that more and more, that the community provides researchers with participants, and the closer we align with the community as collaborators on research all the time, the better it is. But in a humanitarian crisis, it's even more critical, because the community understands itself, it knows where its resources are, it knows what its priorities are. It can provide and support research by giving access to information, to participants, to resources that an outside investigator would not have. So I'm sure Dr. Altice would agree with this, that you embedded yourself in Ukraine, in the community. You enlisted the experts in that community, the educators. You were connected with the universities there. So the local context actually drove so much of the methodology. And I think that needs to be critical. In a humanitarian crisis, it's even more critical, because the community knows itself, as I'm saying. Around sensitive issues, it's there where the recognition that different cultures have different priorities and different understandings. And often what we advance as something that is morally correct here might not be seen as morally correct in another. When we do research, we can put participants at risk inadvertently, and we pay very close attention to that. And again, it's alignment with the community experts that keep us from creating inadvertent harm. by misunderstanding where the connections are, what the real risks would be.
Excellent. Thank you so much. The final targeted question is for Dr. Omahuna. And can you share your guiding principles and experience regarding data sharing and ownership, publication, and dissemination of findings when conducting research in humanitarian settings? Also, how can researchers navigate research data and findings that may be misinterpreted by stakeholders or policymakers?
Well, thank you again for an important and complicated group of questions. And maybe I'll focus more on, how do we find guidance in these types of areas? And I think there's a few things that I would go back to. And in one of my early projects, we worked with R2HC, which is a funding agency in the UK. And they asked us to really look at helping to prepare researchers and research teams around addressing the ethical issues that would come up. And out of this, what we developed really was a booklet of questions that we hoped would be useful as teams would get together to start to think about projects. And I think part of the principle behind all of this is that I think the ethical issues need to be discussed and reflected on from the day that you start thinking about doing some research. That one of the problems that has developed, I think, is that sometimes researchers take the approach that, well, I'll deal with ethics when I'm getting ready to fill out my IRB application form. But before that, we'll just develop the science and the ideas in the project. And that really doesn't work well, because there are ethical decisions being made when you think about where are we going to do research? What sort of a project are we going to be doing? Why do we want to go and do this project in this part of the world or the town that we live in? And so by having questions that the team is looking at from day one, that you can start to think about, well, do we know whether this project really is necessary among this group of people? Do we know if they want this to happen here? And what are we going to do if, like the example you brought up, if our findings are going to say, this particular group has this particular issue, and there's a danger that they'll be stigmatized because of that, or that they'll be treated with violence because it goes against what some other group thinks about what should or shouldn't be happening. So by thinking about the issues right from the beginning, I think you start to see the importance of drawing out the strategies then that can help to avoid ways of stigmatizing people, avoid ways of thinking of a great project and then kind of wanting to go and do it with this group of people, and then realize this is not of interest to them at all. That if the people are engaged with this, if they're part of the decision making around whether this is an important project for their needs, that the research team can then get important direction as they go forward. And I think the other area that touches on some of the things that have already been said is another code of ethics that was developed by a team called the Trust Code for Equitable Research Partnerships. And out of that, they really emphasized what would be called a virtue ethics approach, but looking at the ethical characteristics of everybody involved in the project. And so rather than talking about various kind of principles and ethical theories, they use words like honesty and care. And those are, I think, ethical virtues and characteristics that we need to teach to our trainees and to promote within our research teams. And then that will guide us as we try to think about, are we being flexible here, or are we just kind of adapting because it suits our team to do something a little differently? That looking at, is this really being honest with our participants and their communities? Is this really caring for the people that we're engaging with? That we get better direction, that just thinking about, does this comply with the informed consent procedures, which I think is really what a virtue approach can contribute to these types of decisions.
If I could sort of just add to that, I think that one of the things that sort of emerged, Dónal, is this whole idea of conceptualizing and thinking of these ethical principles as you design your project in response to a conflict, and what are the types of questions that you're asking. And that process is interestingly very different than when you have a project that is already well underway and you're having to sort of adapt and respond, where the types of engagement are both critical, but they're really answering very different questions. How do you continue what you're doing in order to maintain, the highest, ethical, standards of research, and the process of planning for what you're doing, where you're trying to answer a seminal question that is related to the conflict in order to make sure that the participants are safe. And the other part of that is the question you're asking is it meaningful? And is it meaningful to the community, rather than just, something that you're interested in? And that was one of the things that I think that evolved a lot in our research, is because we not only had to maintain, a number of very large projects, but we had to also, we learned from working with our team members and our community boards that they had many other things. And I'm not a psychiatrist, but I can tell you that our team moved to have some psychiatrists involved in our research because those were the questions that they wanted answered. And that planning process with ethical principles happened, but it was interesting. It happened organically. A couple of you all are really trained ethicists, and you think about these things. And I'm sort of an ethicist only because I work with vulnerable populations, and I have Madelon, cracking the whip over me all the time. But it's a very interesting sort of conundrum between both of these different strategies.
I'd like to add just a little bit about that. And I think it goes to your point about having sort of integrity at the base of researchers who are planning. But I want to point out for Dr. Altice and also Dr. Barakat that you're physicians, and you were physicians first before you were researchers. And I think inherent in the process of responding to something, a sudden, you called it a disruption, we could call it a war, right? It was a major disruption. What kicked in was the recognition that aside from the research, there were other needs. And those needs began to pull for what needed to be done independent of what the initial hypothesis was or the initial methodology. And I think it's incumbent on the IRB to recognize when we have a parallel process going on. And the parallel process takes advantage of the ongoing research to address some of the needs that were not really research, but was really the provision of care, the provision of humanitarian care in a crisis. And that's where not only flexibility, but embracing the spirit of what the ethical principles are. Their protection, not applying regulation to get in the way. Yeah. Right. So, and I think that's what you're describing, Dr. Altice, in yours, and Dr. Barakat, when you started the infectious disease process, although research trying to figure out what COVID was really doing pathological was there, but the care was primary.
Excellent comments. Thank you all. And Dr. Barakat, you'd like to add?
So, yeah, thank you. I want to a little bit expand on this point, which I think is very important, which is the ethical conduct. And I think we have to always ask ourselves first why we're doing this research. Are we doing it because we want to improve the greater good, because we want to help, or we're doing this to advance our own agenda, our own career and science? And this was very evident during a lot of what happened globally and specifically in COVID-19. The first thing is what we say is do not harm as a physician. And I think one of the participants brought a very important issue, because patient in this situation can be very desperate and vulnerable because they will take anything. At the same time, they might be very concerned and living in fear that they have mistrust and they will not engage in something that can be life-saving. And we have to take these into consideration, not to take advantage of some vulnerable patient, but at the same time, not to exclude patient who will require a little bit more explanation and appropriate consenting. This is critical in conducting ethically research in a moment of crisis.
Excellent, thank you. Before we turn it over to the questions from the audience, I'd like to go back to some points. Dr. Omahuna was discussing the importance of virtue ethics, and this is the concept of cultivating internal ethical traits as opposed to deontological ethics, which are looking at sort of the rule-based IRB protocol system of ethics. So in the way that our MDs are discussing this as well, and Dr. Baranoski is discussing the approach of treating the individual first and thinking about an ethic of care. I'm seeing a thread through all of this. And Dr. Baranoski had also discussed thinking about avoiding doing harm through a misunderstanding of culture. So I'd like to return to some of these points, and particularly when you have an unstable environment in a setting of warfare and your information, your context of work, everything is changing and it's unpredictable. Considering these important dimensions, where do you turn for guidance? What is the role of the community? When you don't have a clear direction, what are some thoughts on ethical guidance in those settings?
Well, I wonder if, may I jump in? Because I had a student who just finished up a PhD last year, who was a remarkable guy, a nurse from Syria, who did his research interviewing other medical care practitioners in Syria during the war there. And one of the unfortunate findings from his work was that ethical guidelines and kind of codes, the people on the ground felt like those provided very little help, and that instead they were going to their cultural and traditional beliefs and the values of the community and their religious beliefs for guidance on how to deal with questions of honesty, with questions over, do I stay in the midst of this trying to serve my community, or do I take my family and try to get to safety? And that it really does go back to those core beliefs that we have been raised on from, our own community values and those around us. And I think that's where I find that with a virtue approach, it sort of gets at some of those areas where I still think that, regulation and principles and codes do play a role, but that we have to inculcate these values within ourselves, because we ultimately do need to think about what is the goal, the primary goal of being in this environment, whether it's as a responder or a researcher or an ethics committee. And it should really be the care of the individuals who live in this place. And I think sometimes that may mean that we decide not to do research. I was challenged one time at a conference by somebody who said, if you've got a helicopter going into an earthquake zone, are you saying we should take one of the physicians off and put a researcher on there? And I think there could be a moment or a time when no, the physicians are who need to go in there, or maybe the engineers or whoever, and not necessarily the researchers. But that, and again, there should be a time where, as soon as possible, the researchers are going in to figure out, is this working or not? But I think that does come back to those core principles that that we're sort of our ethical natures are built upon.
Thank you. Would anyone else like to add? Thank you. Excellent. The first question we have from the audience now, to what extent can the local communities be meaningfully involved in ethical review and approval of research conduct?
I might start on that one, in part because we've learned something in international research. When if a university is there, the local context is often provided by the university's IRB. And so it's university to university. But very often a university isn't involved. And there are the non-government agencies or NGOs that are involved, or it can be a group that's put together either with church leaders or religious leaders rather, or the care providers, often physicians, but also other providers of care or local providers of care. And what we learned is that the non-university ones are very effective at pointing out what the ethical concerns are, or what the risks to the community would be, or what we've misunderstood, or how things should be approached differently and where the risks might be. So over time, I think the incorporation of actual community agencies, not only academic agencies, is a good way to involve the community. Now, in the middle of a crisis, and I'll go back to that, solving the crisis always has to come first. And while you're doing it, you're collecting data that later can be looked at as research. I mean, you're always collecting data when you're doing that. So I don't know that division has to be as bright. And whenever I see that, I wonder if we're too rigid in what we think of as research, if we're too bound to bench research with the random clinical trial rather than a broader translational research model that might be there. But so I think the community can be involved at the beginning, but certainly in the design of a study, the way to recruit, what's appropriate and who should be included. With this one caveat, sometimes the interest is in a human rights interest that is not represented in the community. And I'm thinking of some communities with LGBTQ populations who are striving for some kind of protection, or sometimes women's rights, children's rights, depending on the community. And there, we're going to define the community a little differently. We're going to combine the community as the participants themselves, the potential participants.
Yeah, and Madelon, I would just sort of echo that when you're really dealing with minority populations, the tyranny of the majority from the community perspective can be really awful under those circumstances. And having them involved in the ethics at that particular point, I think is not necessarily right. But these sort of, one of the things that I know is part of what we do in the kind of, I'm not doing lab research. I guess the community is our lab, right? Is that we really create these community advisory boards. And I don't know that they actually evaluate the ethics, but I think that they really provide the inputs in terms of what types of things may not be ethical to do. And for instance, in a place like Malaysia, where homosexuality is illegal in both secular and Sharia law, they have really guided us that we need to be doing much, much more of our research in the virtual space so that our research participants are harmed at least potentially less, and doing so, with secure interactions, in some cases, new apps that are really somewhat protected. So they do guide us, under these sorts of circumstances. And what's really nice is that even though we try to maintain our human rights and our ethical principles as researchers, they provide a really important guardrail so that you don't reach beyond them. And they come up with incredibly creative solutions. And so, as Dónal said, that planning up front. We went to the Community Advisory Board when we got into trouble with our ongoing research activities, but also when we're planning them, it's, we really have to get them to help us right up front, because some good idea that we did in Ukraine, I can't do in Malaysia because of that context. And I certainly do not want to go to the broader community when I'm working with people deprived of liberty, or people who engage in sex work, or, men who have sex with men in a place where it's illegal, or there's incredible stigma and discrimination that occurs. So you have to decide what that community is. It's got to be the right community, I suppose.
Right. That's right.
Great, thank you all. We have a number of pre-submitted questions. I'd like to turn to Dini, who has a combination of some questions that are coming in during this conversation, and she's going to combine a couple of those as we're short on time. Go ahead, Dini.
Thank you, Laura. So a couple of questions are asking about how does one approach ethical research in a setting when there is no functional authority for local IRB approval or guidance, especially during conflict. And an attached question to it is, let's say a researcher are currently in the conflict zones, and they want to leverage their research skill not only to document or record what is happening, but at the same time inform interventions. So what kind of ethical guidance from local IRB when the local IRB may be not functioning? What kind of suggestions or recommendation would provide to these researchers?
I might just start based on something that happened during a Lebanon crisis that occurred not very, very long ago. And Dr. Kershaw from the School of Public Health was very clear that one of the richness of the academic community is that there are many people from a culture who are elsewhere who can inform us about that. And so we should reach out and know that network, and they often mobilize incredibly quickly. So Dr. Esterlis, for example, is a researcher in the Department of Psychiatry. When the Ukrainian war was in its very early stages, she was contacted by a colleague there who identified that women were being displaced, that they needed protection, and she mobilized a group here, including Dr. Barakat. I think you were involved too. And so she's part of the Ukraine community, but she's not involved directly, so she's available. So that would be one way to reach out. To identify people who are available for information and for providing that. And then one last thing I want to emphasize again, I would be very careful not to label as research bound by the same ethical rules, something that is humanitarian rescue. And we have guidance right now, even from the FDA, that says, okay, we're going to do surveillance. We're not even going to call it research. It looks like research, but we're not going to call it, and nobody has to get informed consent. And that was in service of the question of what is COVID about, or expanded access, where you're using an investigational drug for treatment and you're not bound by the same research rules. So those would be the two ways I would think about it.
And then just to put a pragmatic piece to this, during Ukraine, we, the IRB members, many of them, sort of crossed the border. They were no longer in Ukraine. They had direct communication. They knew the landscape. and they were still able to be functional even though they were not physically present. So their quorum was, online. And so they also came up with their sort of creative ways. So that is the way to have essentially members who understand the context and the landscape. And even if they're away, they have communication with people to really understand what those are, I think is one of the things. And then the other sort of second part of that question is part of what's happening, under those circumstances when you're in these conflict areas is you're really engaging in something that's called participant observation. And, that is, certainly you can't, you have to use what I would call good human rights judgment when you're doing that. And that is research, but it's also a kind of surveillance. You're looking at what's going on. And it, I would say that your own sort of internal clock around or your own, internal barometer in terms of what is ethical sort of needs to apply, but it doesn't really meet those other sorts of criteria because you were making important observations in terms of where there might be opportunities for intervention.
Thank you so much. And thank you to all of our panelists for your invaluable expertise and experience. And I'd like to give Dr. Omahuna a chance to weigh in. And if any panelists have any final comments you would like to share, then we'll turn it over for closing to Julia. Go ahead, Dr. Omahuna.
Yeah, I guess I would just like to respond to something Madelon said about the calling something other than research. That I from everything she said, I'm sure she's not advocating this, but I have talked with researchers who have put a lot of effort into thinking, well, how do I call my things anything other than research so that I can avoid certain rules? And I think this is where, regardless of what the project might be called, going back to things like honesty or like respect is going to be guidance that I think sometimes it's a misunderstanding, I think, of what IRBs are trying to do, but that by viewing it as relabeling, we can avoid certain regulations, but instead thinking about, like the idea of respect. Am I respecting this community and their needs by doing whether it is surveillance or participant observation or research? That is where we should be looking for guidance, not which regulations apply or don't apply here. So I just wanted to comment on that.
Excellent. Any other final thoughts? Those are great words to close on. Any final additions? All right, I'd like to turn it over to Julia Rozanova for our final concluding remarks.
Thank you very much to Laura and to our wonderful panelists for having this inspiring conversation with us. And I would also like now to acknowledge the support that we received from MacMillan Center for International and Area Studies at Yale. And I would like to acknowledge the group that has worked very hard on enabling this panel. So first of all, of course, my partner in crime, Dr. Sheela Shenoi, with whom we've been co-leading the research into HIV and aging in Ukraine that inspired us to be interested in these questions in the first place. Dini and the team of people at CIRA who have been the brain and the heart and soul behind this effort. Irina Zaviruha from Ukraine, who has been suggesting directions for driving this inquiry forward, including suggesting questions, and Alexandra Diak from England, who was my master's student and who has been just tirelessly working on putting this together. And I also want to have a special thank you to my current student, Ruta, who is currently part of the audience. And in conversation with her, the idea for this panel was born because she's planning to write her master's dissertation on the subject. So if any of you are going to hear from Ruta, please know that she was the person who inspired this fascinating conversation that made all of us the wiser. I think that the questions the audience has given us is enough to write many master's theses and many PhD theses. And not only that, but practice. And so I think that I speak for all of us that we have learned so incredibly much, but this is just the beginning of this conversation. So I hope that we will continue this discussion, that now our panelists and many others have identified themselves as ethicists, either by training or by design or by, future aspiration. And now I think that we can do this work collectively together. So thank you very much from the bottom of our hearts, and be safe and live ethically. Thank you.
Thanks to you, Julia, and the organizers. Thank you.
Thank
Thank
you.
all.
Thank you.